I'm Al McFarlane. Welcome to the Conversation with Al McFarlane. Today is Friday, May 26, 2022. I'm glad to be here and glad to be with you as well. Thank you for being part of this experiment, this gathering on the digital plane, connecting, building community, sharing our thoughts. That's what the Conversation with Al McFarlane is all about. And if it's Friday, our special focus today is on healing. We call this the Healing Circle, and I'm joined by colleagues, friends, leaders, healers, talking about the question of how do we move towards maintaining health and wellness, well-being. How do we heal our bodies, our minds, our families, our communities? How do we discover pathways to being our best selves? How do we look at the challenges and understand them, put them in perspective so that we are not immobilized and destroyed, but rather we are strengthened and we learn ways to navigate challenges, navigate in a way that builds memory, builds strength, builds capacity, and builds the kind of success that we seek as human beings. Well, before I go into the program, two things. One is that I want to invite you to support this conversation. And the way you do that is go over to the Insight News channel on YouTube. Now, we stream this program on about 5 different networks. We're on the Black Press USA YouTube channel. We're on the YouTube channel for Insight News. I want you to go there before we leave. We're also on Facebook for NNPA. NNPA is the National Newspaper Publishers Association. It's called Facebook Black Press USA. We're on the Insight News Facebook page. We're on the Al McFarlane Facebook page. We also are streaming live to Twitter. We're streaming live to LinkedIn. And wherever you are, however you're connecting, thank you. Let us know where you are by going to the chat or the comment section and say hello. I see Brother Power 96. Good afternoon, brother. He's at the Black Wall Street Legacy Festival today. And he says, let the summer road trips begin. Brother, thank you as always. And Michelle Madison is here. Her organization, Michelle's Delicious Delights. Greetings, Brother Al, and distinguished guest, Michelle. Greetings to you, and thank you so much for your loyalty, your presence. Well, so wherever you are, drop a note in the comment section. Let us know where you are, questions. We'll shout you out. And before we begin, I want to thank or acknowledge a partnership we have with Minnesota Department of Health, just to keep you reminded and us reminded about COVID. You know, the emergency or the pandemic has been declared over, formally, officially, but we are invited and encouraged to keep thinking about things we can do personally to keep ourselves healthy and safe. For example, and I'm showing you an ad that's running from the Minnesota Department of Health in Insight News. The ad says, wash your hands. And it's a simple thing, but we are saying that, presenting that ad in 6 or 7 different languages because all of us have a need to make sure we focus on the simple things that can keep us safe. So we start by saying, wash your hands, be conscious, be aware. Let's do things in a way that protect us from COVID-19 and other maladies as well. We'll do one more shout out to the Minnesota Department of Health before the program is over. But I really want you to know that you can go to Insight News and see that invitation to do things that will keep you healthy and keep you safe and well. Well, today I want to start by bringing in Dr. Bravada-Garrett Akinsanya and Dr. Oliver Williams. And our special guest today is Dr. Willie Garrett. We've got a great conversation, a great topic. I'll set the topic and then we'll go into the protocol of how this meeting is going to run. It's a wonderful thing that we always do. And the topic is Black men's mental health. It's an important thing. And I'm going to share, as we get into it, information, a story that says, African American men feel good about their health, but preventive care is lacking. That'll be the jumping off point for today's conversation. So first of all, welcome, Dr. Bravada-Garrett Akinsanya. Dr. B, how you doing?
I'm doing very well, Brother Al.
It's so good to see you, as always.
Thank you.
And let's go ahead.
I was going to say, let's get started with our protocol.
Let's do it.
So we normally start in a circle, and even though it's virtual, we feel like we're all here together in spirit. So we believe in using a virtual circle because in African tradition, the circle represents the whole village. Everyone in the circle has equal access to the center, which is the place of power. So no matter who you are, you have access. The other reason we sit together is because we are orderly and we use a talking stick to pass the voice to one another. So somebody can have the stick going around and around. Somebody can ask for it out of turn and receive it. And that piece of our coordination of voice is because African people are orderly. One of the other things we do is we recognize our elders in this circle. We recognize them because our elders are the shoulders we stand on. And we honor our elders because they're closest to our ancestors. And we honor our ancestors because they're closest to the Creator. So this sacred space of being in circle with one another is a place for growing, for shedding tears, for laughter, and for healing. And so today I welcome everyone who is joining us to the Healing Circle in our conversations with Brother Al McFarlane. So I'll pass the talking stick back to you. Bye-bye, Al. Yeah, I've lost Sam.
You what? Did you say what?
Miss Al, you muted.
Am I still muted?
Apologies, I had my mute control on, so I was going to say thank you, Dr. B. Let's begin by welcoming our colleague, Dr. Oliver Williams, and our friend, Dr. Willie Garrett, and begin this conversation. And I mentioned that we want to talk about the question of health, and I had come up with an article that talked about Black men feeling good about their health, but still there's a question about access, how much access there is, how much we actually have. Before I pull that up to talk about, let me just ask Dr. Williams and Dr. Garrett to weigh in on the general sense, your sense of how we Black men feel about our health in general and our mental health in particular. Dr. Williams, going to pass the talking stick to you.
Okay, thank you, Brother Al. Around health and mental health, is an interesting thing. I know that oftentimes there's a sense of, at least in past generations, there's been some reluctance to seek mental health services, but also health services. And everybody knows about the Tuskegee experiment that certainly contributed to the issue. But, even in my personal experience, I had to, when I first got to Minnesota, I had to change doctors several times. I had one person until I got an African-American doctor, and actually had a white female doctor who was really pretty good, who got me connected to African-American physicians. And when I've had other doctors, white male doctors and doctors from other cultures that didn't understand the propensities for African Americans to suffer through different challenges, it was very challenging for me. And had one physician, I asked for the tests for prostate cancer. And so he says, well, I don't want to give you that test because you can get false positives or false negatives. And I said, well, I'll pay for it. And so he says, no, I'm not going to give it to you. Interestingly enough, a month after I had asked him for it, he kind of disappeared. And I went to another physician, white female physician, who was up on a lot of things. But what she did was she recommended an African-American male doctor for me.
Mm-hmm.
And that guy was gold. And then he left to do something after probably about 5 years. And he got me connected with another African-American doctor who was again gold. I've had other doctors that were good to, looking at different things, but I went through a whole bunch of them, literally about 10. And I realized I have a degree in public health. And I remember in one of the classes, one of the things that they talked about was the fact that sometimes people don't know that they can say no and that they can choose other people if, they've had some difficulties. And that is one of the things that they talked about that would help people, to try to get the health that and get the reports and get the attention that they need is to be able to deny it or complain. So I did, and then got connected with somebody that was pretty good. Went with her for a while, but then got connected to a physician that was pretty great. So but that's still, there's still something about us having reluctance to go to people that can help us, or challenging different medical environments.
Mm-hmm.
And sometimes that has something to do with our feelings of inadequacy, and also fear of what medical assessments take place and how we feel about that. We've got to challenge that as well. So with that, I'll pass the talking stick back to you, Bubba.
Well, let me thank you. Let me pass it to Dr. Willie Garrett. Dr. Garrett, thank you for being here again. It's good to see you again. And know that this is one of your areas of expertise. So, your first, in response to the proposition, but the statements that Dr. Williams has made to begin with, first thoughts, first feelings, first observations. And you have to unmute Dr. Garrett. There we go.
There.
Here you go.
Well, it's good to see Dr. Williams. Haven't seen him in a while.
I feel the same way.
And I agree wholeheartedly with what he said. And, I am more of a child adolescent psychologist, although I see adults too. But it was about 30 years ago that I participated in a study about child-teacher interaction in the schools. And what we did is we had a tally sheet. We had a student and a teacher at an elementary school go around, and they had a tally sheet of behaviors between teachers and students. And the students were various racial groups, and so were the adults. And what we found was very alarming, because what we found is that the teachers were not doing things such as calling on African-American students, weren't looking at them, weren't praising them, and their main interaction was something negative. And what we see with the health system is a similar kind of thing, with therapists as well as medical doctors, where they don't look at, they don't ask questions, they don't offer you the full range of service. It's like they're trying to get you out of their office pretty fast, and this has a harmful effect, of course, because people walk away, Black men especially will walk away and end up not getting the care that they need. And of course, over time, the problems get worse, and then they have a serious illness that's going on. So a lot of this is invisible interaction that happens between a professional and the African-American person, whether it's man or woman. We recently saw how the high infant mortality rate and the high death rate of Black women giving birth, how there's a difference, how they're twice as likely to survive if they have a Black doctor. So, that's one of the big issues. The other is that there just aren't enough African-American professionals, aren't enough African-American doctors, nor therapists. And so
let me interrupt you, Doctor. I'm just floored by the statement you made about the difference in outcomes when people have African-American doctors. What does the research say? Why is there that difference? I mean, I think we all kind of anecdotally and suspect, but what does the data indicate, and what does the industry, the profession, attribute that difference in outcomes to?
Well, it has to do, again, with negative stereotypes. I mentioned that much of it is invisible. There are a lot of behaviors that African Americans show, nonverbal behaviors, and about maybe 50 to 80% of our communication is nonverbal. And so it has an unconscious impact on us, that those unconscious nonverbal behaviors. And so when you're with and I hate to keep picking on white people, but when you're with a white person who's raised mainly in a middle class or upper middle class white environment, that's almost all the white professionals, they operate by nonverbal behaviors for their culture. And many of the nonverbal behaviors that African Americans present are seen as negative or suspicious. And so, and just some of the little things, like we tend to look away twice as often as a white middle class person. And when we look away, it's twice as long. We take twice as long to answer the first question that you ask us. And we have twice as many pauses and twice as long of pauses as white middle class person. And this results in that white professional having a negative image of that person. They think that either they're lying, they're hiding something, they don't have pain, or they don't have certain needs, that they're not interested, all of those things. And the worst case scenario that you see for that is with police stops, because when African Americans are under any kind of stress, they tend to present more of these behaviors. And what happens is that there's a clash of cultures and a police stop. Mm-hmm. And so that escalates into violence, because the officer will talk to this person. And I've had it happen to me too, where I feel nervous when the cop stops me, or even just being around police, I feel nervous, and you start showing those behaviors and they think you're hiding something, you're being suspicious, and you have a weapon or something like that. And again, it escalates into violence. Those are examples of those things. A lot of it is invisible. A lot of it has to do with the media, especially, like the 2020 FBI and Department of Justice statistics show that 69% of the violent crime is done by white people, actually. 69%. Black people, they said 27%. And then it was very small numbers for Asians and Latinos and Native Americans. But there is this image that there's violence that's going to happen, and a lot of that has to do with the media, because the media doesn't portray, you won't see 69% of the violence being portrayed as white people in the media. You'll see a Black person being shown over and over and over and over again. And I recently had a white female say to me that 90% of the crime was committed by African Americans. Mm-hmm. And I talked with her about these statistics, and let her know that that is just not true. It's really not true. but we won't see it in the media. Recently, there were 5 boys from Edina High School, which is one of the wealthier suburbs in the Twin Cities, who did a carjacking right outside of their school. And they were arrested, but there's been nothing on the media about it since then. And my guess is that they got a slap on the wrist and were sent back to school instead of to jail. My guess is that they probably weren't even arrested. They were probably just taken to jail and their parents came and got them and they went back home. But they committed a carjacking. But you don't hear about that. You don't see that. And I work with rural psychologists. There's a lot of rural crime that people don't hear about. Right. And it's not the same as urban crime, but there's still a lot of crime, especially with property issues, property damage and break-ins and fights that may not involve a lethal weapon, a lot of domestic violence, all those things you don't hear about. So this gives everyone, I mean, it has a negative impact on us as an African-American person because we see it every day. Whether we think about it or not, it's affecting us unconsciously. And it's definitely giving white people the wrong impression, really, about who we are and how we are as African-Americans. That's a long answer.
Well, that's a great answer. Let me take the talking stick back and thank you. You know, that's a great answer. Let me get into the article we pulled up to look at this conversation today. And it's a piece that was presented in AARP's publication. The headline says, African American men feel good about their health, but preventive care is lacking. And it says there's encouraging news because a recent survey of Black men in the U.S. who are over the age of 50 indicates that most of them feel good about their health, but they say more preventive care and better lifestyle choices could mean even better health, and that what's lacking or hindering the progress is lack of access. So AARP conducted this national survey of more than 1,200 Black men to get a snapshot of their physical and mental health experiences with healthcare providers and views on disease prevention. 3/4 of the respondents gave a good, a very good, or excellent assessment of their physical health. 83% gave the same positive marks for their emotional health, and 84% gave the same marks for their mental health. It says, though, that the study did discover some disconnects. They found that 80% of Black men who are 50 and over are aware that eating a healthy diet and maintaining a healthy weight will lower their risk for serious health conditions. And most believe they're eating well, but 42% acknowledge that they are overweight, and just 24% meet the recommendations for exercise every week, and only 23% get enough sleep. So I'm going to stop there. We'll go back into more parts of it. The article talks about smoking, drinking, and mental health. It says, it gives numbers about how many Black people over 50 are experiencing high stress levels. With that, Dr. B, let me pass the talking stick back to you to reflect on the opening remarks from Dr. Williams and Dr. Garrett and this article about the status of how Black men feel about their health.
Let me take it to add some things because I think she took a pause.
Okay, so, go ahead, please.
One of the things that I wanted to also kind of suggest with regard to my experience with going to physicians, when I was telling you about the physicians that wanted to deny me the tests, the fascinating thing was the fact that the medical service that I went to had a protocol that suggested that you do test African-American men in a certain age group. And they said that they wanted to test them because there's a propensity to have higher rates of prostate cancer.
Mhm.
So it was in the protocol for the medical environment, but this particular physician didn't want to use it and wasn't aware of it. He was concerned about the cost of it, and I'm saying I'll pay it because I knew that there were higher rates of prostate cancer among African Americans, but it was built into the system. He didn't know about it. I guess I wanted to ask both you, Brother Al, and you, Dr. Garrett, about when you go to the physician, do they say things like, do you need a doctor's note to go back to work?
That's never come to me because I'm the employer, right? And so I don't get, and I think they know, my doctors all know that I'm the entrepreneur and the manager, and I haven't had the experience of even being asked whether or not I need to stay away from work. In my mind, I've been very healthy and haven't been hospitalized, and but I can't recall being asked, if I need either extra medication or being time off work. I haven't been ordered off work either that I can recall. So,
well, for me, it's happened more than once, and I don't know whether they knew what I did. As a matter of fact, I knew that they didn't know what I did, and so they made the assumption that if I came in to get something, I guess I didn't come into the emergency room, but I scheduled an appointment to come in, that I was there and that I needed to have some doctor's note to be able to justify me coming in for a health review of some sort. And so, and I keep wondering about that, and it's been my experience. I'm glad it's not yours, but for me, it's a repeated thing, where people make some assumptions about who they think I am. And I don't know how other people feel about that, or whether it's a common experience among the other Black men.
I had an experience with one physician, not my regular doctor, but another doctor in the clinic. Health Partners came in, and he happened to have somebody, maybe an intern or a resident, a learner with him. And I remember them coming in and him doing the examination, but the feeling I had was that I wasn't there. This was a conversation between this older guy and an older white guy and a younger white guy. And I could just as easily have not been there, or could have been there as a cadaver or as a chart, as anything, but I did not get a feeling that my actual living lifeblood humanity, was the center of the visit. Rather, it was their observation that was important. And my life, it seemed to me, to them, was totally irrelevant and inconsequential. And that was a bad feeling. That was the first time I felt that. And I don't like that. And so, I want to engage people that I'm paying to be and to support my healing. And so I take the attitude that I am the healer for me. And I walk into the service or seek the service of others who are specialists in helping me affect and attain the healing that I seek. But ultimately, it rests in me. That's what I believe. But I think I've come to that over time. And I think early on, I think I had probably what would be a very, very, very average attitude that you, a doctor, you must know everything and I must know nothing. And so my job was to sit here and to listen and to, and don't worry about big words and big concepts. Just, follow instruction. I don't know. That's been my experience as well.
That's why I think they came up with the term cultural humility.
Mm-hmm.
And they dealt with it with regard to trying to engage patients in a medical circumstance to be able to share and to inquire about issues that people may be going through, because you can get a lot of information. I think we had the conversation before that sometimes people's experiences may be somatic, where they describe their physical circumstances as being connected with something that may not be physical. And it's in that sometimes physicians do exactly what you say, Al, with regard to not communicating, seeing past you, not being able to gather information from you to help get insight in terms of how people are dealing with things. So cultural humility is kind of assuming that you need to get information from the people that you're, the patients, for lack of a better word, that you're working with. And that tends to be a challenge for some people, because they may, like you said, they may think that you're that they have as much insight about your physical circumstance and don't need to engage with you interpersonally to be able to get information. Well, they say that's a problem, and the problem is the fact that you're missing something in terms of dealing with people that you're trying to heal and work with physically. So what do you think about that, Willie?
Well, my experience has, both personally and with my clients, and I've seen quite a few clients who are Latino and Hmong, the whole full range of colors of people. But drug seeking, an assumption of drug seeking consistently has been a problem. And I've had doctors say to me, when we're talking about pain, they say to me, well, I don't prescribe opioids, and so I've had that happen to me more than once. And I wasn't asking for opioid. In fact, I wasn't asking about any painkiller. I don't like painkillers. I'll take just over-the-counter stuff. But they made it a point to say, I don't prescribe opioids and things like that. But I've had to advocate for my clients because they have had problems with their doctors around this issue of drug seeking, and also with pharmacists. And I have one woman who has schizophrenia, and I've worked very, very hard to keep her on her medications, right? And she has done well with taking her medications, but there have been times when she has walked out, because either a doctor or pharmacist says something about drug-seeking kind of behavior. And the medications she's trying to get are psychotropic medications. They're not pain-related, they're not addictive, anything, but the pharmacist or the doctor will say something that suggests that she is drug-seeking. And it creates extra work for me as a therapist, because I have to see a lot of clients, and then I have to make phone calls, sometimes write a letter. I have to go much farther than your average middle-class white therapist does with a client, because I have to use my privilege at being a professional to make sure they get the care that they need. And so that's been my biggest experiences just with drug seeking. I had a Hmong woman with the same thing, where, she talked to her doctor about giving her medication to her children. And it was a situation where the doctor didn't take the time to understand what was going on. He was about to call child protection. And it just so happened that the clinic that I worked at, they had a mental health department and a medical department. He came over and asked me to come help him out. So I came over and I asked the woman a series of questions, just a series, help me to understand, tell me what you do, stuff like that. It turns out that when she went to the pharmacist, the pharmacist, this pharmacist was trying to be nice. There's a white pharmacist who's actually trying to be really nice, but her 10-year-old was the interpreter for her with the pharmacist. So the pharmacist was saying, this medication is going to help you to sleep better. You're going to have more energy. And so in passing through the 10-year-old, it came across to her like it was a vitamin. And she has a sharing culture where you share a lot or share everything, you know? And so she talked to a doctor about sharing it with her children. He thought that was child abuse and was ready to call child protection. And when all we had to do was get an interpreter and help her to understand that this medication was just for her, that it wasn't a vitamin, and the problem was resolved. But this woman could have easily ended up with child protection. Could have easily ended up with a child protection call. Yeah.
That's exactly right. I keep thinking about the misinterpretations of something that within a culture is seen as healing. But for people who don't understand, it could be problematic. I've heard people tell stories about, with the Latino families, the fact that they're going to call Jesus to come. And so that's Jesus in English, but they would call Jesus to come and be able to get his impression about something. They're literally talking about somebody named Jesus and not talking about Jesus in a spiritual sense, or in Hmong culture, if they use coining, and that means to get something that a hot piece of a coin heated up so you can put it over a child's body to be able to draw the illness out. But Neil Tao, Dr. Neil Tao, ended up doing training with me years ago, and he said that those are things that got kids into child protection because they saw it as something that was abusive, and it wasn't. The intent was something very different, but from a cultural perspective, or the lack of knowledge of a culture is seen as being abusive.
Yeah.
And so that's like cultural chauvinism. That's one of the ways to describe that. There's a certain arrogance that the profession has, that academia has actually. And academia, the academic tradition in the country, seems to not differentiate between facts and values. That there's a underlayment of values. The value beneath is the proposition of the right, the cultural right, the cultural what's the right word for it? I'm getting at this idea of arrogance, where they feel that our culture affords us. They called it the white man's burden for the long time, right? And that is to take their sense of the way the world operates and impose that on other human beings. And that they call that being helpful as they were enslaving other human beings, right? And so how do we get to where we can see that and say it more? I think we're seeing it and saying it more. We're calling it out. But I think we have to also teach ourselves then our responsibility for our own health in an environment that still is based on somebody else's sense of who they are, of their humanity, and your lack of humanity. That's the battleground as I see it.
If we shifted to look at, we could still look at, African-American men in particular, but another example is how the country is dealing with health and women. Was it South Carolina or was it Arkansas? I forget which. And they were banning women's right to choose. And that there was a woman who was with the Supreme Court in a particular state, and that she retired, and then they ended up taking it back for a vote, and the legislature was only men that was voting on it. And for men to not know things and the way that they're trying to structure things, to not know issues associated with women's health And I guess in this one case, there was a 10-year-old girl that was raped, and that the physician and the court ended up making a decision that this child needed to be helped and not have carry this child full term, and that it was a group of men that ended up making the decision that they were just going to outlaw it. And what I have not understood historically is why men who are not physicians and want some who are physicians, but will make the decisions about women's health without being a woman.
Yeah.
And so those things trouble me, but it's been the case too, in terms of looking at historically African Americans and mental health. There were times when these negative judgments were placed on us, and people would make decisions about what went on or the characteristics of African Americans by going to white people who weren't knowledgeable about African Americans, but made judgments about African Americans. Because people, and it's kind of like grants too. When you're applying for grants, sometimes there's organizations that have a good reputation with their community, but sometimes it may include something about diversity, but have nobody that has any expertise about that population.
Yeah.
And then they give them funding to be able to do that work without having to make accommodation and then being inclusive in a real sense, rather than a peripheral sense.
Yeah.
Of including diverse leaders in the community to help them make better judgments about what they do. So.
Yeah. Yeah, I agree. I think that Black men, in terms of health in general, do better when they have a peer or some other African American male who they talk to, who can direct them or encourage them to get the care that they need, and to give them the support to go the extra mile to get the care that they need, because there are huge health disparities.
Right.
And two of the biggest ones are within our community is breast cancer, that Black women die at a way higher rate from breast cancer. And it varies from city to city, because I read that in Philadelphia and Boston, Black women die from breast cancer close to the same rate as white women. But if you go 700 miles south to Atlanta, the death rate is twice as high.
Right.
And we know that affects relationships. It affects when the wife, the mother is ill, it affects the whole family, And the same thing with prostate cancer, as you mentioned earlier, Dr. Williams. North American Black men have the highest death rate from prostate cancer in the whole world. Now, think about that. I mean, you think about all these poor countries out there. I mean, we have a higher survival rate if we go to Ghana or to Nigeria than to be here, right here in Minneapolis,
Right.
And you think, what? How can that possibly be? But that's what the numbers show, the highest rate in the world for prostate cancer. So there's clearly health disparities. I mean, there's not much genetic difference, I wouldn't think, between the Black men born here and those born in Africa, or other parts of the world. It wouldn't seem like there would be much of a difference, from that standpoint. So something is happening there with that. Clearly it's happening there. Clear health disparity. And again, it affects the relationships and families and our mental health as well.
Right.
Dr. Garrett, I had two questions out of your comments just now. One has to do with what you just said about the propensity or the doubling of the death rate for Black women in Atlanta versus a northern city. How does that stack up against the question we raised earlier, presuming that when there are Black physicians, there are better outcomes? And my presumption, and maybe I'm wrong, is that most of the physicians that Black people see in Atlanta are Black, but that might not be true.
That might not be true.
It might
No.
not be true. That's number one.
Yeah.
Second question is just in the context of what you were saying, Dr. Williams. I've raised this with women on this show from time to time. And how do we look at the nature of the society being organized as a patriarchal hierarchy? The hierarchy is patrilineal, a patriarchy.
Mm-hmm.
What difference does that make? And are there other models and systems of organizing society that bring a different appreciation of, and this was, sparked by your comment about women and women's health. Is there another way of looking at how power is both observed, used, shared, owned, that can produce different results? Because right now the paradigm is the command of the patriarch, and the way it's stacked up in the West is white men, and then the hierarchy on down. What do you think, Dr. Garrett and Dr. Williams?
Well,
is there a discussion in the Black community about patriarchy, and should there be?
I think that there's been some discussion, but not to the extent that it needs to be. So there are a couple points that I wanted to bring out. One is that medically, one of the issues has been that some of the models in terms of health hasn't included women. And so as we take a look at different issues, historically, a lot of the models were focused on white men. And so and what's been happening more recently is that they have included more considerations associated with women and women's health, which gets you better insight in terms of what outcomes can happen associated with them. But there have been things where people just didn't know enough. And then the other thing is kind of like what Dr. Garrett was talking about, including Black women in the mix, to try to be informed about their health status and how they're affected, by particular things. That's something that I think is important. One of the things that I struggle with around domestic violence is the fact that, we talk about things that are important in our community. Violence towards African-American men are things that are important among, in terms of youth but also in terms of adults, and what we do within groups associated with particular problems. But I don't think that we have largely been able to walk and chew gum at the same time when we talk about violence in our community with regard to men and with regard to women. Women suffer domestic violence, but I've done this work in this area for a long time. And when we talk about women's experiences with violence, sometimes we don't want to have that conversation. I remember I used to have an institute for 25 years, and I tried to bring urban leagues and other civil rights groups together to have the conversation about the issue. And the thing was that you talk about males and males violence and violence by the police. And I'm a Black man. I agree with having those conversations. But how come we couldn't really engage with what was important regarding violence against women? And that's a problem. We've got to be able to talk about that and then deal with within our own community, have the conversation ourselves within our own community about violence against women. And we still have some reluctance. I also think that there's a power struggle with that, and I think just sometimes we expect people to change or women to change when it's not an issue about women changing. It's an issue that we have to confront ourselves. Now, I'm not saying women can't be violent, but men can be violent. The rates of violence by men to women are higher than the rates uh, uh, women to men.
Yeah. Yeah,
And
Doctor. Oh, sorry, Doctor.
no, go ahead.
I was just going to comment that in the news yesterday, there was a story about an 11-year-old black boy who was shot by a police officer.
Yeah.
And they totally missed the point that it was a domestic violence situation. No one, really addressed that matter. It started out as a domestic violence situation. The boy called 911.
Mm-hmm.
And when the boy came out with his hands up, the officer shot him. At least that's what they said on the news. But they missed the point about the domestic violence.
Right.
They did.
Right. Yeah, and making good judgments about what to do in those circumstances.
Mm-hmm.
You know, I've seen different situations where if the police come and try to handle a situation around the issue of domestic violence, and then a black man gets killed, then sometimes what they do is blame the female for calling the police.
Mm-hmm.
Now, there's two issues. One is that the police have to use better judgments about what they do, because we've certainly seen in cases, that case in Wisconsin, where they had a bunch of police that were around the situation. They ended up shooting this guy in the back when they could have handcuffed him and taken him in. But I've seen situations where if there's a black man that gets killed, they'll blame her for calling the police instead of being able to try to figure out different ways to respond to circumstances much differently. There's a woman named LaVon Morris Grant that I've interviewed in the past, and so she tells the story about how the community blamed her for her husband that committed suicide.
Mm-hmm.
And the police came to try to deal with the circumstance, but they blame her for his death. And she made an interesting thing. She said, if I had the power to change him, but I couldn't do that, what made you think that I had the power to be able to change that circumstance if he ended up, because he shot her 5 times.
Mm-hmm.
And then he committed suicide. And then she's saying to the community, I didn't have the power to be able to do anything about it. And those are conversations that we've got to be able to have. And prevention is one of those things. We've got to be able to go to human service organizations to get it formal and informal. Mm-hmm. Churches, some people have told me should be a spiritual trauma center. Mm-hmm. But churches have to be equipped to be able to refer people to different places. And I've seen it. I've seen it in Mississippi and in Detroit and in Boston and in Seattle, where people are preparing their church environments to be able to hear somebody who's coming in with that complaint, but then to refer them, if not have that faith house be able to provide the support themselves. And to get people come sooner. If they go to churches or if they realize that resource exists within the community, they may go there first before they have to call the police. And so we've got to revisit how we think about things. And this is the same thing about men. If we had men who were able to connect with other men about their behavior. I have a brother who talked about going to a barbershop, and there were other brothers that were there that didn't know what he did. And he ended up hearing them have a conversation around domestic violence, and he ended up being able to share. But there was also other kinds of chatter that was there that were supporting the guy that was being violent, and confronting him and saying being abusive isn't the right way to be able to do it. Because I remember saying that, if you think that control is the way to deal with things, dealing with domestic violence is like putting your hand in a pot of water and trying to grab it to hold on to the water. Can't do that. You got to be able to rethink how you approach dealing with circumstances, and we have to do that too. And in terms of health, it's the same thing. Well, brothers should be able to talk to other brothers, about health and going to seek help and having conversations about those things too.
I keep saying, Dr. Williams, Dr. Garrett, that part of the challenge is that we have to adopt the mantra that our health is our business. By that I mean that we have to be in the business of our health ourselves, and that we need 45 more Dr. Oliver Williams and 45 more Dr. Willie Garretts, people that are trained, that are knowledgeable, that are in our community, that know our history, that speak for us. Listen, we're out of time. Thank you so much. I want to remind people, though, in closing, that our partners at M.P.H are reminding you to pay attention to ways to prevent the spread of COVID-19. The pandemic emergency has ended, but COVID still is present and possible, and you can do practical things every day. One thing is to go get a copy of Insight News. I'm showing you the advertisement from the Minnesota Department of Health next to the advertisement from Dr. B at the African American Child Wellness Institute. But the focus is on health. Let's make health our business. I'm Al McFarlane. We'll see you next week.